Neurology, pathology, childhood primary brain tumors. All right, so now we're on to the childhood brain tumors. Once again, my least favorite discussion are brain tumors, but I'm going to try to break it down for you to understand it easily. So first we have the pilocytic astrocytoma. So just astrocytoma. This is going to be from an astrocyte origin, right? So it's going to be astrocyte cells origin. And so that means, once again, it's going to stain positive for GFAP, okay? Now, what they want you to know is that it's going to be usually often found in the posterior fossa, specifically at the cerebellum, okay? So keep that in the back of your mind. Lastly, on histology, you have these things known as Rosenthal fibers, okay? And they're like these eosinophilic corkscrew fibers. What they will describe it as is cells with hair-like projections and corkscrew-shaped fibers. That's just the Rosenthal fibers, all right? But they will say cells with hair-like projections and corkscrew-shaped fibers. All right? That is all you need to know for pilocytic astrocytoma, the astrocytomas. All right? Next is medulloblastoma. Okay? Once again, not too high yield, but usually what you're going to be seeing on histology, what they want you to know is that you'll see Homer-Wright rosettes. Okay, Homer-Wright rosettes. Take a look at what they look like on histology. All right, they're small blue cells, okay, and they surround a central area of like pink, all right? You just have to know the histology. It's very, very important, okay? This can send, once again, drop metastases to the spinal cord, okay? So if you see drop metastases, it's medulloblastoma in a kid, okay? Truncal ataxia can also be seen because the cerebellar vermis can be involved, but it can send drop metastases to the spinal cord. All right? Very high yield that medulloblastoma sends drop metastases to the spinal cord. All right? Next is going to be the ependyoma. All right? Ependyoma is going to be from ependymal cells, ependymal cells. And so it's going to be most commonly found in the fourth ventricle because that's where ependymal cells are, right? They're lining the ventricles. All right? So make sure you know where the fourth ventricle is if I show you a scan of a CT scan of the brain. Because I remember a question where they pointed at different areas of the brain and they said, all right, where would an ependyoma be found? All right? Ependymoma, sorry. I honestly don't know how to pronounce those. But either way, where would it be found? So make sure you know where the fourth ventricle, like where you can point out the fourth ventricle at, right? It's very easy, but just take a look up, where's the fourth ventricle on CT scan? And you should be able to find it, all right? And that will give you a question, honestly, on the exam potentially, all right? Now, it can cause obstructive hydrocephalus, right? Because if you have a mass located at the fourth ventricle, then it can cause obstruction. So you can have obstructive hydrocephalus, which leads to increased intracranial pressure, as we know, papilledema, and headaches, okay? So we know that classical presentation of obstructive hydrocephalus, all right? Next is craniopharyngioma. If you see something that says like a pulp of developing teeth or cholesterol crystals or motor oil-like fluid, they're talking about craniopharyngiomas, okay? So it's like cholesterol crystals, motor oil fluid found within a tumor, pulp of developing teeth. They could say so many different ways of saying that there's just like gunk and nasty stuff in craniopharyngioma, all right? Now, what is it? It's derived from the remnants of the Ratkes pouch, hence the ectoderm. But you guys already know that, right? We already discussed that previously, I think in Repro. So it's derived from remnants of Ratkes pouch, and it's going to be the most common childhood supratentorial tumor, okay? Once again, calcifications are so important. You're going to see calcifications, cholesterol crystals, and motor oil-like fluid, all right? Now, it may be confused for pituitary adenoma because it's located at that same area and can potentially cause bitemporal hemianopia, all right? So just keep that in the back of your mind. So craniopharyngioma, once again, it has calcifications. It can potentially cause bitemporal hemianopia. It has cholesterol crystals, motor oil, and it's derived from the remnants of Ratkes pouch, which is from the ectoderm. Lastly is the pineal gland tumors. What you need to know is that it presents with obstructive hydrocephalus because it compresses the cerebral aqueduct, which is the location between that sends fluid between the third ventricle to the fourth ventricle, all right? So you have presentations of obstructive hydrocephalus, non-communicating hydrocephalus, just as we saw in the ependymoma. And it leads to 1, papilledema, 2, headache, 3, increased intracranial pressure, and 4, potential vomiting. All right? So keep that in your mind. That's the classical signs of obstructive hydrocephalus, those 4 things. Now, it can also lead to paranoid syndrome, and that's just compression of the dorsal midbrain. So what you're going to see is a typical triad. You'll see triad of upward gaze palsy, you'll see nystagmus, and then you'll also see light near dissociation, which is pseudo-Argyll-Robertson pupils. So Argyll-Robertson pupils, remember calling back to micro, is essentially a sign of syphilis, congenital syphilis, okay? And what that means is that your eyes will essentially accommodate, okay? So pseudo-Argyll-Robertson pupils accommodate, but they do not, like your lenses accommodate, but your pupils don't shrink when they flash light on them. All right. And so it's the same thing. The reason they call it pseudo Argyll-Robertson pupils is because it looks exactly like Argyll-Robertson pupils, but it's not caused by congenital syphilis. It's caused by paranoid syndrome. All right. So it's the triad of the upward gaze palsy, nystagmus, and the pseudo Argyll-Robertson pupils. All right. And that's paranoid syndrome caused by pineal gland tumors. All right. So that's all for the childhood primary brain tumors. Just keep in mind, once again, the same things for the adult brain tumors, and you should be set to go.